Afternoon, doctors, nurses, and all the audience. You're all welcome to today's webinar. Today, we shall be considering surgical emergencies in newborn. Discussing today is I myself, Dr. Kefaras, consultant pediatrician, and here our pediatric surgeon, Dr. Robbie Sampson, our senior colleague. This is being broadcasted from Limit Children's Hospital. And of course, our other branches are, this is the Limit Hospital groups. And we have the cardiac care, and also we have the Limit Multidisciplinary Hospital at the central area. Our vision is to empower Africa through healthcare training, research, and also health delivery. You see some of the pictures of our nurses and our doctors. Our services are very extensive, extending from neonatology, neonatal intensive care unit services, transport incubators for transporting our children from place to place. We have pediatric cardiology, we have pediatric surgery, as we are discussing today. We have also neonatal pediatrics emergencies, we have developmental medicine, and also we have endocrinology. The outline of what we are looking at today is as displayed above. By way of introduction, neonates are children from birth to 28 days of life. And neonatal surgical emergencies are actually common. They can be defined as emergencies which only immediate surgical intervention that can successfully treat it to prevent mortality and also severe morbidity. Many organs can be affected, but today we focus more on the digestive system, but the list is inexhaustible. So most of them are congenital, but few are acquired, like talk of necrotizing enteric colitis, that's neck. Comprehensive care for these children really are multifaceted. Hence, we have high index of suspicion to be needed by all involved. Whether you're a nurse, a doctor, anybody caring for these children, you have to have a high index of suspicion so that alarms can be raised as early as possible so that to avoid delays that can lead to some severe consequences if the right thing is not done at the right time. So we need coordinated efforts, and also we need good precision in diagnosis because some of the diagnoses are done even in utero. Hence, when we talk about doctors, we're referring to both, not just pediatricians, we're talking of different aspects, even gynecologists that are taking care of the children in utero. The diagnosis, if you do ultrasound, what will you find, to make a diagnosis? So our diagnostic tools need to be precise, and also the skills of the radiologists and also the obstetricians that are doing the scan is very, very important. Also, we need speed in making the diagnosis and also intervention. As I said earlier on, some delays can lead to some severe consequences. Like the one practically I could say is, if a child has volvulus and have extensive resection and anastomosis, and that child is now suffering from short bowel syndrome, it's a very horrible thing to deal with. So if it can be avoided, it will be well used. And of course, our surgeons and also people that take care of these neonates need to be meticulous. You can see a preterm baby, 1 kg, need to go to theater. Sometimes the parents will say, this child is not too tender to go to theater, but we know the condition that the child needs to be operated upon. The surgeon will have to go in. So we are very meticulous in handling this kind of children. And also we need adequate pre and post-operative care. Also, we need sustained supportive care for the children. And other life-threatening, potentially life-threatening medical conditions, we need to be given concerted effort. Let's say maybe anemia, and if you not take care of anemia, it can spoil the success of that surgery, or maybe parental nutrition. So other things need to be done, and also some other conditions in the children, like the respiratory support and others, need to be taken good care of, because the surgical aspect is only one, and other things need to be done. Holistic care of the children is very key. So now, what are the pathogenesis and the pathology and pathophysiology of the surgical conditions in these neonates? Most of the causes are unknown because several times you find the parents will say, what caused it? Is it the kind of food I eat? Is it a kind of drug I've taken? Mothers will say, is it something I need to do anything I didn't do? That is why this thing happened to my baby. Of course, most of the causes are unknown, but from studies on that vascular accidents in utero during the development of these children, if there is compromised blood supply to various on any segment of the bowel or any part of the organ, and it cannot lead to ischemia, and also respective segment of that bowel can fail to develop. It can lead to narrowing of that very part of the organ. Narrowing will cause stenosis, or complete obliteration of the lumen we call atresia. Of course, there are some genetic conditions, several genetic conditions that have not been elucidated that are related, because you find that some of these they run in families, or the incidents are higher in the family. So that shows that there's genetic connection. Then environmental factors are believed to have played several roles in some of these. But of course, basically most of them, the causes are unknown. I believe my senior will have one or two things to say about that. So do you have anything to say about that?
Generally speaking, the causes of congenital anomalies, in this case, largely unknown. But like he rightly said, the unknown causes account for more than 50%. And the environmental causes, there are certain things, that certain behaviors that can be modified that may sort of help in reducing some of the congenital anomalies that may eventually present as surgical emergencies. For instance, things like things that would aid the development of the baby, like vitamin A, folic acid. These are things that mothers can be encouraged to take, and of course, the avoidance of the prevention of those deficiencies will, in one way or the other, contribute to ensuring that we have a healthy baby at the time of delivery. Exposure to some form of radiations, can also contribute to anomalies. So it would be important to advise people who work in areas where they're exposed to a lot of radiation to take precaution, particularly for those who work in X-ray departments, for instance. They're supposed to have some form of metering that gauge how, the risk of the exposure to these radiations and all that. So on and so forth. And people that, for instance, that are taking some medications, like people that have some diabetes, high blood pressure, people that have some convulsive therapy, for instance, anticonvulsive therapies. Some of these drugs may affect the development of the baby. For instance, in patients that have what they commonly refer to as imperforate anus. Some of these things have been found to be implicated, as causative agents for this. So some of these ones can be modified, and serve in a way to prevent some of these occurrences. Of course, genetic causes, they are still evolving. So you cannot really say that, oh, this is the cause of this, but they're largely related to either form of mutation or translocation of some of the genes. And as they evolve, and of course, as genetic engineering and the studies are evolving, some of these causes will be better elucidated in the near future. But for now, most of the causes for some of these anomalies are largely unknown. And so the key thing is to be able to diagnose them and manage them early in order to ensure that these children survive.
Thank you very much, sir. So looking at the digestion I was talking about from the esophagus, what are the things that will occur at the level of the esophagus? Talk about the esophageal atresia, that's the commonest, which always most times go together with tracheoesophageal fistula. And the duodenum, you could have duodenal atresia, duodenal stenosis, and other things that can occur around there, like the annular pancreas. Then the jejunum, the ileum, you can have atresia or stenosis. In the colon, the Hirschsprung disease, you can have microcolon, you can have many other things that can occur at the level of the colon. And coming back to rectus sigmoid, talk about the H-bones. They're also coming down to the rectum, like imperforate anus. So all those, they are things that can occur as a result of what all those things we talk about as the risk factors or maybe as likely causes, even those largely we don't know. But most of the things that can occur, like you talk about the obstruction, and if there's obstruction, what will happen? You know, we're talking about pathophysiology, okay? Then we're now talking about the fluid, the foods, the secretions that need to flow, that need to pass. If there's no obstruction, there will not be stasis. And also, you now start talking about regurgitation or vomiting as a result of that, or distension, the proximal part of the gut that has been obstructed. You have distension, and if you have distension, what can result? You can have the vomiting can lead to dehydration, and also there are several other things like electrolytes that can be lost through that. Of course, if the problem persists, the child can have weight loss and also the failure to thrive. Of course, when we talk about infection, when there's stasis, there will be the commensals can now become infective, and also you can now have infections, and infection can result into septic shock and several other things that can cause shock. Then we talk about the gut ischemia and perforation proximal to the portion that is affected. And also when you have perforation, then more fluid can be lost through the perforated part of the gut. And also you can talk about peritonitis, and you can talk about the shock, you can talk about touch space loss and several others. Then we talk about the upper, we talk about respiratory distress, which can occur as a result of what? Can be as a result of maybe like esophageal atresia when there's aspiration of secretions of feet, and also when there's like maybe like duodenal or lower GI or small bowel obstruction. If there's abdominal distension, there can be splitting of the diaphragm, and also that also can lead to respiratory embarrassment and also respiratory failure. So I know, sir, you have more to add to this?
Yeah, well, largely the pathophysiology is just trying to explain why certain things happen as a result of the problem that's been envisaged. I think we have discussed generally. Most of the things you said will be repeated as you look at some of the various pathological conditions along the GI tract, because basically they all result in some form of obstruction or the other. And that is the way it is. So I'm sure by the time we get to discussing some of the specifics, we'll be able to go into some more details.
Thank you, sir. So what are the principles of management of children with surgical emergencies? How do you make the diagnosis in the first place? So remember we mentioned about obstetricians, the role they will play in making the diagnosis. So the diagnosis starts from the prenatal stage. So what are the things that maybe if you notice during the antenatal period that it can spark off your suspicion for a surgical condition that will come in? So things like maybe polyhydroamnios, oligohydramnios, okay, maybe fetal ascites, or maybe you notice peritoneal and that's peritoneal in the peritoneum, maybe that can have some perforation, adapt even in utero, and you can have some leaks in the peritoneum. So all those ones they can happen even in utero. Then the obstetrician need to have angels of suspicion and also do some anomaly scan and to find out what exactly is the cause of this. Though because we know there are surgical causes of these conditions and also there are non-surgical causes. So at least the surgical causes, the earlier is noticed, the better. Because even in the days in the advent of fetal surgery these days, some intervention can be started much earlier, and also some of the interventions may even lead to taking some decisions whether this thing is going to be compatible with life or whether there will be a decision in which this child maybe they need to terminate the pregnancy. Those are all things that can happen even prenatally. So and postnatally, if the child is out, then some of those symptoms that we mentioned earlier on, they can manifest, and also you can now tie those symptoms together and also start making a diagnosis. Then the investigation we said earlier on needs to be precise so that I don't start carrying these babies. You know, first they are just struggling, they are out, maybe some of the symptoms with respiratory distress, and maybe some of them with distension, and maybe dehydration and several other things, moving the children from one place to another. We need more precise. So our investigations should be specific, and also they need to be highly skilled person, so that you don't have to go in back and forth in making a diagnosis. You do X-ray before you know it's not clear. Go back again. All those kind of stuff. So we believe we need to be very precise, and we need to be very meticulous, and also the kind of the instruments that we have, or the machine that we have, need to give the right diagnosis at the right time. So at the postnatal age, and the investigation can be done prenatally or also postnatally. Of course, some of the investigation, most of them are imaging like X-ray, okay, X-ray, abdominal ultrasound, and also investigations like CT scan can be employed, but most especially also contrast studies. Contrast studies are very useful in making diagnosis of most of these pediatric surgical emergencies. Of course, so how do you manage the children? Of course, you need to resuscitate and stabilize them. How do you do that? Of course, you need to follow the ABCD of resuscitation, okay, so that you don't miss out on anything from the breathing, okay, from the airways to the breathing to the cardiovascular system. Also, any medication to be given, and also complete exposure and examination of the children is very important. Then the issue of referral is very important. If you know that in your center, that's why if you make the diagnosis in your center, you won't be able to handle that kind of child, then it's better the child will be referred in utero. However, if the child is already out, then further delays may worsen the morbidity, or may cause mortality. So it's better to consider referral. Then remember, we mentioned also transfer. How do you transfer these babies? They're delicate children. Most of them are premature. How do you transport them? So you need things like mobile incubator, if some premature babies, for proper thermal regulatory control. Then other children you need to use, like just this week alone, we have some situations in which a preterm baby referred without oxygen. So without ambulance. Just yesterday, we admitted a child in that situation, a premature baby. So those kind of things, they are very common, and so we believe the essence of doing this kind of presentation is to educate ourselves more and to prepare ourselves more, so that we optimize the children better, so that we could get a good outcome. The definitive surgery will be done by surgeons, which most of the time they need to be very prompt, and also, as I said earlier, be meticulous, and the post-op care. And I believe when we go to specific cases, maybe we'll discuss more about that. So these are some of the prenatal signs we mentioned: polyhydroamnios, oligohydramnios, fetal ascites, dystocia, like this hydrocephalus. If a child come with hydrocephalus, of course, it can cause dystocia, it can cause obstructive labor. These are some of the things that we see. So these are things we talk about, maybe Oligohydramnios, we talk about how often are they, and some of the common things that you could see as a result of that. Of course, diaphragmatic hernia is one of the things, and other non-surgical conditions. Oligohydramnios, renal agenesis, PUV is one of the things that can occur them. If there is premature rupture of membrane with amniotic fluid, you can see that, and placental insufficiency, and also all these things will result into lung hypoplasia, because the amniotic fluid required for the development of the lungs. So if these problems start much earlier in pregnancy, then the lung development will be severely affected, and it's one of the things that is making the prognosis of these conditions very bad. So I don't know whether there's anything you need to add before we go to the next, which we'll be talking of diaphragmatic hernia.
Well, just to emphasize that prenatal diagnosis is very, very important. In our environment, is something that is relatively not well practiced, but it's something to emphasize, because we're talking about newborn surgical emergencies. Very, very important, because once the diagnosis is made prenatally, it is advised that except you have the requisite facilities and the personnel to manage the patient, that patient is better transferred to a center where there are services and personnel to handle them. For instance, if you maybe you're a gynecologist and you happen to scan happy to take a history from a woman, and there is history of polyhydramnios, I mean, an unusually large for dates, pregnancy, and you decide to scan and you see that the woman has a very large amount of amniotic fluid. So that tells you that something is happening. And basically, you need to understand why it is so. It is so because the fluid that the baby ought to be swallowing is not getting into the intestine. And as a result of that, that fluid is kind of vomited back or regurgitated back into the amniotic. So that adds to the volume of the fluid. And there are conditions that can, like we try to display on that slide. Particularly, first on the list would be superficial atresia. And if that happens, of course, if it's in the hand of those that are experienced with ultrasonography, they will be able to detect that even the gastric bubble may not be there. And of course, by the time these babies are delivered, like we will soon see, there are telltale signs that will give it away. And so sometimes too, you will find things like diaphragmatic hernias, high intestinal atresia presenting in similar fashion. But what we find sometimes is that, in our experience, that patients are told by those who manage them, when I say the parents, that your baby is fine, and only for them to be, faced with the challenge, a baby being born with severe distress, and you ask them, say, well, I did 3 ultrasound, and they told that the baby was very fine. They showed me the baby was kicking, the heart was kicking, and that is the story, and that is not good enough. So we need to up our game in terms of what we do to be able to have a very good outcome for these babies.
Thank you very much, sir. Yes, it's not just to overflow that, because several cases when some of these neonatal diagnoses are made, even some syndromic cases when the babies are out, and when they say they've done several scans and things, the child now came out with something. Actually, it's very demoralizing to the parents. So we believe that, as we said, we need to up our games. We believe that we need to increase in our skills. We mentioned earlier on precision in making the diagnosis. It's very important. Before we progress, there was a question by Dr. Samuel. We saw it in the Q&A box. The long hypoplasia is not a cause of oligohydramnios, but it's a consequence of that. That's why it's being starred in the slides. It's being starred as the consequence of that, because there's oligohydramnios, the lung development will be affected. So it's not like a cause, it's like a consequence. Okay, let's move on. So just to overrun this, I repeated some of the symptoms that can occur postnatally: respiratory distress, some use scaphoid abdomen, excessive mucus secretion and salivation, abdominal distension, vomiting, which could be bilous or non-bilous. Okay, they all mean 2 different things, and there are some that are more cynical than others, like the bilous vomiting. Okay, failure to pass meconium, and failure to develop transitional stools, and also hematemesis or hematochezia. They all portray one form of troubles or the other with these children. Then abdominal masses can be felt. So like bilous vomiting, when the child vomits, the first thing is the doctor will ask, what's the color? Try and look at it. They may not tell you, but they may not tell you exactly. Try and look at it. Did it spill on the cloth? Did it spill on the diaper or whatever? Then try to look at it. But once we see bilous vomiting, it's one of the signs, it's one of the symptoms that's actually very, 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 can be dangerous, okay? Because I have serious fear for intestinal malrotation with volvulus. It can be very, very serious. So what are the lesions that can cause respiratory distress in these children? Just going through some. We may not look at all of them, of course. As we said, the list is very long. So we'll look at just few. But Things like coronary atresia can cause that. Esophageal atresia with or without TEF. Okay, diaphragmatic hernia, laryngeal clefts. Okay, we've seen some of these cases in the course of the practice. Then tracheal agenesis, then congenital lobar emphysema, cystic adenomatoid malformation, biliary tracheobronchial communications. So we'll first look at congenital diaphragmatic hernia, and after that we'll look at some few other, especially like GI obstruction cases. So this the incidence between 1 in 2,000 to 1 in 5,000. Okay, but 1/3 of the cases they are born dead, so they are stillbirth. But males are more affected than females. 80% are on the left because of the foramen of Bogdale. Then 2% occurrence increase in first degree relatives. Remember, we talk about genetic components. Even though they may not be elucidated, they may not say this is the gene that is affected. So the etiology, of course, we said is not known, and some environmental factors may be involved. Then osseous abnormalities can involve skeletal, cardiac, and tracheobronchial trees. Then what are the pathologies? It can be detected within the first 12 weeks of life. So within the first trimester, it can be picked. So remember, we talk about prenatal diagnosis. So remember some of the things that are the risk factors. Okay. So the left side is affected more. The defect can be between 2 to 4 cm, but it can be more than that because sometimes some of the components will involve even the liver. Okay. So the content can be intestine, could be liver, could be spleen. Okay. And depends on the level, depends on the length and also the amount of the organ that has been there, then it can affect the lung development. Pulmonary hypoplasia and also pulmonary vascular resistance will be high. Okay, there could be increasing hypoxia. Okay, and left to right shunt will be high. Remember, we talk about other things that can complicate things, especially the pulmonary hypoplasia, one of the things that can affect the prognosis. Then how do you make the diagnosis of that? Prenatally, you can diagnose by ultrasound up to even 40 to 90% of cases. So our high suspicion should be able to help us to make some of the diagnosis. Then the average age in which you can pick that to be around 24 weeks. And polyhydroamnios is found about 80% of the cases. Then postnatally, you talk about the respiratory distress mostly within the first 24 hours of life when you want to start feeding the child and not start experiencing regurgitation and also aspiration. And you know that yes. And when you start noticing respiratory distress as a result of immediately after birth, as a result of the pulmonary hypoplasia, you start noticing that the abdomen most of the time will be scaphoid because most of the abdominal content will be moved up into the chest. Okay, but some of them actually can be maybe just small segment that may be there. Because I remember there was a case that we diagnosed after 1 year. There was a case that we diagnosed after 1 year, they were able to diagnose that the child has a diaphragmatic hernia. So the symptoms can actually delay because actually some of them, they will be visiting hospitals, going to several peripheral hospitals, being treated for pneumonia several times, and maybe the child will experience some small relief, then before you know, they are back again. But eventually, some of them were diagnosed late, experienced one. Then of course, when you do chest X-ray, you discover that the contralateral side of the deviation of the trachea to that side, and also you can now, during examination, you could pick bowel sound in the chest, and also in the chest X-ray, you see the loops of bowel in the left side. Later, you will see this picture is showing us the esophagus is there, and also you can see the aorta. So beside the aorta, that you see the abdominal contents will go in through there. It's because the defect is much. Then this X-ray is showing the child with bowel in the left chest, So you can see that there is shifting of the heart and the mediastinum towards the right. Okay. The management of these children, of course, there shouldn't be ambobagging because so that it won't increase more air into the lungs. And also, these children need to be intubated as much early as possible. So the NG tube needed to decompress The mechanical ventilator, most of the time, if it's available, we need to use, and also to allow transition of vascular and pulmonary function to pick up. So most times the surgery should not be just rushed to be done, because you need the lungs to stabilize, you need the lungs to start recovering. You need something like that. Otherwise, the pulmonary hypoplasia and the respiratory challenges can frustrate the process of the procedure and also the recovery. Of course, you need to correct metabolism and acidosis, and also parenteral nutrition is very important, because those kind of children, you may not need to just rush to start feeding because of the fear of that. So the surgery, the earlier it's done, the better. So parenteral nutrition needs to be done to optimize the weight of the child. So I don't know, they have something to add?
Well, yeah, that for the congenital diaphragmatic hernia. Previously, people, when they diagnose it, immediately the child is born, they rush to operate. And the outcome is usually a very high mortality. And that is because of what he has said. There's a lot of derangements, physiologic derangements that ought to be corrected. And the child has to be stabilized before surgery is undertaken. The lungs are so important to the survival of that child. So the contralateral lung in particular has to be assisted, to function. And that is why if you're going to bag them, the likelihood you're going to cause some form of barotrauma. So that's to be avoided as much as possible. Most of them, with little respiratory support, are able to survive first 72 to 96 hours of life, where they are being prepared for some form of surgical intervention. And of course, like you said, there are some actually, there are even some adults that have diaphragmatic hernia, but are living almost normal life. Okay, some have been discovered or diagnosed accidentally following investigation for some other chest conditions, and you just find a loop of bowel hanging somewhere and has to be done. Now, the only thing to say here is that the diaphragmatic hernias, you know that during the development of the embryo, during the embryonic development, there is a common peritoneal cavity, as it were, extending from the neck down to the pelvis. But about the 6th to 10th week of life, the diaphragm develops. And when there is a failure of closure, about the 8th week, a failure of closure of the pleuroperitoneal membrane, which tends to separate the pleural cavity from the peritoneal cavity, that area becomes open. So the length or the diameter of that defect will determine how much of the bowel that will herniate. And how does actually the bowel gets there? The bowel gets there following, when the baby develops, really, we understand that there's what we call physiological herniation, wherein the gut, moves out of the into the extra embryonic cavity, and again it returns back into the peritoneal cavity because there is a disproportion between the growth of the intestine and the abdominal cavity at that time. So the growth of the intestine finds their way out of the peritoneal cavity, primitive peritoneal cavity, into the extra peritoneal cavity. Now, about the 10th week, there is a return of those intestines. Now, so when they return, there's the area that is open just provides an access for these bowels to occupy. And when that happens, so you will have a hernia occurring in that area. Now, it could also affect the right side, but the right side is less common because the liver kind of provides some form of covering. And on the right side, it's more muscular than what happens on the left, which is more like a membrane. Okay, so the fibers, the diaphragmatic fibers are less on the left compared to the right, and of course aided by the factor of the liver, which tends to prevent some of the bowels easily herniating through any area where there is a defect on the right. But of course, diaphragmatic hernias also occur on the right, but they are less, compared to the left. And when patients eventually have this and they are treated at with 1 week, 2 weeks, 3 weeks postnatally, the outcomes are better than when we rush to operate within the first few hours of life in order to save them.
Thank you, sir. So the surgeries are basically making incision or laparoscopic or thoracoscopic approach, and the viscera are gradually reduced back to the abdomen, and the defects are primarily closed, and a patch may be used, and the abdomen will be closed. The prognosis, 80 to 90% survival rate, as I said earlier on, depends on how the surgeons, how the optimization of the child is done before the surgery, and also the post-op care. One of the things that will affect the prognosis is the lung hypoplasia. Depends on the degree, and also the other congenital abnormalities that can be related to the condition, most especially like the heart conditions. Okay, let's look at the esophageal atresia. I saw questions. Any questions from the group here? From the one I can see here is we've already answered that. The chat box. Okay. Okay. Let's move on. We'll answer the questions that's there already. We look at the esophageal atresia and also the TF, tracheoesophageal fistula. Okay, the incidence 1 in 4,500 averagely. Okay, males to females are equal in occurrence, and 0 to 2% in siblings. If one sibling is affected, can be increased, and 20% if two siblings are affected. Then one of the popular associations we talk about in surgery is, you can see it in esophageal atresia, the Bactal association. Okay, the vertebrae, the anorexia anomaly, okay, the cardiac, the tracheoesophageal problem, and the renal issues, and also on the limbs. They are all some of the associations that you can notice. So if you see a child with some of these problems, you have to examine the child properly. And that takes us back to even examining the children right from the beginning. Okay, when a child is born, anywhere, whether it's in the primary healthcare center, in general hospital, tertiary or quaternary hospital setting, we need to examine the children well so that we don't overlook some of these things that could occur. So once we see one abnormality, what they used to teach us is, when you see one abnormality, you look for others, right? So it's very important as a doctor, as a nurse, as you examine the child, you try and examine in total. I remember that's one of the SOP, that's the one that's standard, of course, in our labor room, there's a standard. And also on our server, on the Helium Plus, there's a place for general physical examination of the newborn. So it's obvious, and it's not born out of just SOP, but it's born out of clinical information and also clinical experience.
Yeah, let me say something here. I think it's important to emphasize this point, particularly for midwives. It's expected that a child that probably has esophageal atresia should not have a problem of being fed. So every baby that is born actually should have an nasogastric tube pass, irrespective of whether the diagnosis was made or not. Because even if you've done the ultrasound by the best hands, they will still miss some. So if you pass that NG tube, it will be arrested. And once you have that, then of course, there will be no need for you to put that child to breast immediately. Because the consequences of doing that are so grave. Because when it happens and that child, of course, will aspirate, will choke, as we will see later on, it actually, compounds the problem of that child and makes early surgical intervention a challenge. So I need to emphasize that point as we make progress.
Thank you, sir. So to say type C is one of the commonest, in which there's esophageal atresia, then there's distal tracheoesophageal fistula. Okay, so these are the first two. There is no connection down, and of course we know that in this kind of children you discover if they say some that have absence of bowel gas or of stomach gas and gastric and gas in the stomach, and also of course obviously this kind of children you find the abdomen will be scaphoid. Okay, but most of these other cases you see them, but this is the commonest between 80 to 85% of cases. 85% of type C, then these are the other ones. The H type, which is one of the ominous one that sometimes it's difficult to diagnose and can be diagnosed at later part of life. So, but of course, later on we'll see how they present. Okay, prenatally, as we know earlier on, issue of polyhydroamnios, 2/3 of cases. So it's not all cases that there must be polyhydroamnios. Okay, then small or absent stomach bubbles, as I mentioned earlier on ultrasound, then the ultrasound should be able to predict. You can predict up to as high as 40% of cases. Then postnatally, as we said, except salivation, feed regurgitation, of course, cyanosis will result if the child starts aspirating the feeds. Okay, then respiratory distress will manifest, and also inability to pass NG tube, as we said, is one of the things that occurs. So, of course, when you pass NG tube and also in case you apply air, you didn't hear the air in the stomach. Those are all ways in which to convince you that yes, you are having a problem. Then gastric distension will occur in those that are having distal fistula, because as the air enter the trachea, it can now enter through the fistula and enter the stomach. So as the child is breathing, as maybe you are giving the child oxygen, or maybe the child is breathing, gas will be entering the stomach. So the diagnosis is, as we said, failure to pass NG tubes, one of the things that's very important clinically. Then chest X-ray will show the tube coil in the upper esophagus. Okay. Then some may use water soluble contrast, but it's a very risky procedure, and it's a procedure that I know it's not everybody that's able to do that, because sometimes if some contrasts are aspirated, ideally they are supposed to be given and removed immediately. But maybe my guy will say more about that. Then distal air in the abdomen X-ray confirm the presence of fistula. The H-type diagnosis can be done later. Normally it's picked earlier because it's difficult to diagnose, especially when, of course, the child is feeding successfully. But the issue of child maybe aspirating, some small aspirates happening, the child having cough, then most times they may not even present to the hospital. Or even they present to the hospital, they can easily be sent back, you know. Okay, these are one of the pictures of baby, the NG tube is passed and is arrested up there. Then the X-ray is the upper esophagus. This is the atretic portion in which there's a pouch here. So it's believed that you can apply as maybe 15 mils of air into that. So maybe tell us more about this contrast, or do you do that? Or you've seen them do? Tell us more about that.
Okay, well, the first thing, like I said, is the NG tube. Once the nasogastric tube is passed. Now, it's not every nasogastric tube that will be appropriate. So we recommend that you pass a nasogastric tube that is rigid, preferably a size 10 French gauge NG tube. If you pass a size 5, size 6, it's going to coil, okay, and it's not going to be able to give you false. But you need to pass a tube that will get arrested at the pouch and will not buckle. So you need something that is stiff. So that's why we prefer that. Maybe for preterm babies that the nurse may not be able to admit that, you can go through the mouth instead of going through the nose. Okay. So once you do that, basically by the time you advance that tube between 10 to 12 centimeters, it will get arrested. It will get arrested. So typically, because at the level of T2, you find that pathology. So once that happens, it gives you an idea. But in case that there is a doubt, okay, that is when you probably need to do some form of contrast study. You can do an air contrast, or you can use any of the soluble contrast that you can easily soluble contrast, because if it gets spilled into the lungs, for example, you use a barium, it's quite toxic, and it can have deleterious effects on the lungs, and that is why we wouldn't want to use that. But of course, if a child has been if a child has had a suspicion of having this pathology through history of polyhydramnios and prenatal ultrasound that suggests that there's absent gastric and all those stuff, then of course, by the time you pass the NG tube and you find this, there will probably will be no need to start going ahead to do all these other investigations. If it will be done, like you said, it has to be with a lot of caution, particularly the contrast medium. If it must be used, it should be a soluble contrast that can easily be used and then suction out immediately so as to clear the pouch. Because if it's not done, the child will eventually aspirate it.
Thank you, sir. So, preoperatively, it is minimize aspiration by stopping the feeding if we notice it earlier on. Okay, and the suction the blind tube continuously. The child should be need per oral, then start making arrangement for parenteral nutrition as early as possible. The child should be propped up most times about 30 degrees or so that to avoid regurgitation when the child is lying flat. Then early surgery can be done for those with short gap, but those that have long gap, of course, you need to optimize the child properly, because that process will take not just a one-stage procedure. Gastrostomy need to be done so the child can be fed through the tube, and also most time they are prone to infection, so most time they will need antibiotics support. Then the surgery is to ligate the fistula and the primary anastomosis of the segment if it's short. And the long ones may need to take some stages of procedure, elongation of the esophagus. Okay, they may be interposed with some portion of the gut, or sometimes there are some other more advanced way of doing it. So maybe we have some other more things to add on that. Those in the advanced country, other things they could do in order to help us to take care of these children, especially those with long gap.
Like you rightly said, what you just outlined is the principles of management. What I need to emphasize here is that he talked about doing a primary repair. In our environment, primary repair is a little bit of a challenge because we have late presentation of most of the patients, and late presentations are usually accompanied with a lot of morbidity. But where patient presents early means within the first 24, 48 hours, where the lungs have not been corrupted by aspiration pneumonitis, in which case you probably now need to manage and ensure that those infections are controlled before planning surgery. Outcomes are good. Now, but for those cases that present late, and what would you do? Now, you need to know that one of the problems with these children is the issue of drooling of saliva. They drool saliva. So because the amount which saliva is produced is active, so saliva will continue to be generated. So these babies be at the time that we are going to do a feeding gastrostomy, we do what we call cervical sphagostomy. So we bring out the pouch, the cervical pouch. We bring it out and then connect it to the neck, so that the saliva that the child is producing drains out into some form of receptacle at the neck. So that prevents the risk of aspiration from the saliva that the child is generating while the child is being optimized. Now, for patients that have long segment, when you talk about long segment, what do you define as long segment? There are segments that are probably more than 2.5 centimeters. And of course, or children at the length of the deficit is more than 2 vertebral pieces. So when you have this, it means that it will be difficult to bring the ends together without tension. So those are the challenges. Now for these ones, a lot of maneuvers can be done over time by way, for instance, if you are you're still interested in doing a primary repair, for instance, there are ways that that pouch, okay, that we talked about, that you could bring out as a cervical supracostomy, you are not going to do that procedure, okay? So you're going to leave that pouch in place, and I'm going to keep this child onto a dedicated low suction sump pump that will keep the upper pouch dry as much as possible, okay, while this child is being fed. And of course, some of the processes that we undertake in managing the patients like this will have to be modified, okay? There has to be some form of dilatation procedures that will be taking place through some bougies, and you dilate proximally and distally, and then you measure this over time. And once you're able to achieve a reasonable increase in the length, of course, this child, how will the child feed? The child has to be on total parenteral nutrition. So once you're able to achieve this and the child is growing, you're able to control that, then this child can now have the surgeries done where we can now do a primary repair for them. Yes, usually for most long gap, what we do is a replacement esophagostomy. Try to replace esophagus by using that part of the colon or even the stomach, as the case may be, depending on what the surgeon is conversant with. So that can be used to bridge that gap. Sometimes you just, if you're going to cause a gastric tube, for instance, you have to use part of the stomach to reconstruct the gastric tube and connect to the stump, the proximal stump of the esophagus, so that the child can feed. And a child that already has a cervical esophagostomy, you already committed that child to replacement esophagostomy. Okay, we're not going to be able to use that segment anymore. So that is why it's important that if we're thinking of doing a primary repair, okay, we need to be very pragmatic about managing the airway, because if the airway is not good, then outcome is likely to be poor. In fact, the airway, the status of the airway is far, far more important in determining outcome than even cardiac anomalies, because cardiac anomalies can also be repaired. Most of them cannot be repaired. Okay, but when there's so much infection that's not controlled, the child is likely to succumb to those infections, despite whatever you want to do.
Thank you very much, sir. At this stage, I want to show you some of this diagram. This is the upper pouch, and this is the fistula. You can see the fistula is being ligated, and this is the anastomosis between the proximal and the distal portion, right? So let's appreciate Dr. Al-Mustafa from Apapa, Lagos. We have seen your comments. We thank you for joining all the way from Lagos. So let's make progress. So of course, he has already highlighted on what to do concerning the case. He has already concluded, but these are just some of the complications that could arise from the surgery. You can have anastomotic leak, you can have esophageal stricture, you can have recurrent fistula, you can have tracheomalacia, you can have delayed gastric emptying, also you can have refluxes. They have things that are very important. Then some recurrent cough, sit back kind of cough. You can have those as some of the problems. Then prognosis can be good if it's managed, diagnosed earlier, and also managed earlier, especially to avoid contaminating the lungs, up to 95%. Then of course, actually lower in some cases, because like if the child low birth weight children, I believe that 20% of the cases can occur in babies who are low birth weight, and 20% of another case can occur in those who are preterm. Okay, then associated congenital abnormalities of the heart. It's some of the things that affect the prognosis. Then severe associated abnormalities of other major organs. Then the lung gap, you can imagine what he's talking about. The process, if it's lung gap, how the process exteriorize the upper pouch, all those ones, affects the problem. So the lung gap actually has a poorer prognosis compared to the short gap. Then ventilative dependency, that means the lungs has been compromised and the child is totally most of the time depending on mechanical ventilator, trying to win off mechanical ventilator on oxygen. You have difficulty. That kind of child may have a very poor prognosis. Okay, we'll just look into some few intestinal cases and show. That will continue that. Thank you, sir.
Yeah, thank you for your audience this far. We just look at one or two causes of obstruction or surgical emergencies in a newborn. And like we said at the beginning, when we talk about the principles of management, that largely it applies to most of these conditions, and even the pathophysiology, because at early points of the anatomy of the GI, once there is an obstruction, that child is going to present as an emergency. So, so duodenal atresia is failure of, usually the word duodenal means is part of the duodenal. Atresia means failure of development. So it's something that affects parts of the duodenum in such a way that a segment of it is not developed, in which case there is no continuity of the normal duodenum. And what happens is something that you can find the incidence is about 1 in 500, 5,000, about 1 in 10,000. So could be associated with some other conditions. But one thing I need to mention here is that children that have duodenal atresias, they should be, if possible, should be really look out for Down syndrome, because a large percentage of them will have Down syndrome. Unlike other intestinal atresias, duodenal atresias tend to be associated with Down syndrome. So please, let's take note of that. Now, there are other associations, other anatomical associations that's like annular pancreas, intestinal malrotation, all these can be associated with it. How do these patients present? Next slide. They present with features of obstruction. Usually the child is born, and within the first 24, 48 hours, we begin to see a child that is born that suddenly starts vomiting, and the vomiting is bilous. Like we said earlier on, that bilous vomiting is dangerous. That was the word he used. So when you see that, it's a sinister sign, so that something is obviously wrong. And for us as people who look after these children, we need to be very conscious of this and be aware of it, so that once you see a bilous vomiting in the child, you don't go to sleep. That child must be worked up. You need to know why that child has a bilous vomiting, because it could be that this child has a malrotation, and this child having a volvulus, and it's only manifesting as bilous vomiting. So duodenal atresia will manifest as that. Intestinal malrotation will manifest as that, particularly with malrotation. So we need to have this so that we are able to intervene at the appropriate or the nick of time. Now, so the child vomits bile, and of course, if this is not properly managed, this child will come down with dehydration, with electrolyte, this electrolytemia, and of course, this child may go into a state of shock. So that is the reason why we need to quickly make the diagnosis. Of course, when you see a child that has these conditions, what do? The child is feeding is stopped, intravenous fluids are commenced if they were not commenced before, and then the blood samples are collected for total, what they call the complete blood count, and then you do the electrolytes. All these are in view for correcting any anomaly that may have occurred, or that is going and also to prevent the occurrence. Because if, for instance, your results comes out and the values are borderline, then you need to manage in such a way that you start maintenance doses of each of those electrolytes that are at risk of becoming depleted, particularly the potassium and the sodium. All right, so that is done. So we pass an NG tube, we pass a urethral catheter for these children. And when we do this, so we are able to get whatever is coming out of the stomach, and we're able to quantify it. And that guides us in also managing this child, because ideally the vomitus is not supposed to be. So it's a kind of what we call an ongoing loss. So we need to replace that quantity of what is coming out from the NG tube, volume for volume, pending when these children are ready for surgery. And even after surgery, continue in the same fashion. Otherwise, you will give your IV fluids and this child will remain dehydrated. And of course, the consequence of that is that you may end up with acute renal shutdown, because this child eventually develops some form of tubular necrosis from dehydration. So you see, a problem that starts up there can actually go down and cause other things that can lead to the demise of this child. So that is at the time of birth. But like we said at the beginning, prenatally, you may find that a child that has duodenal atresia may actually present in the mother as, that is in utero, as a feature of polyhydramnios. So the mother may present with a large for date pregnancy, and when the ultrasound is done, the sonographer may find features consistent with that. And of course, postnatally, when you suspect this, we do an X-ray. And the X-ray, you will see the feature, what they call the double bubble appearance. And what is this double bubble appearance? Is a finding of a big radiolucency in the gastric area, surface area, where if you look at the anatomy, where you find it, the stomach, you will find a bubble there. And about to the right of the vertebrae, where you're supposed to find the duodenum, you'll find another bubble there. And beyond that point, you would not find any lucency in the abdomen. Rather, what you'll find will be a ground glass appearance, a ground glass appearance, homogeneous opacity, which suggests that there is no air getting below that point. So that is what's called double bubble appearance. Once we have this, it means that nothing is going down. That's what it means. Next slide. So once you have the child like this, like I said at the beginning, so you have to start your resuscitation immediately. And once the child is optimized, the only way to manage this child is a surgical exploration of the abdomen and identifying the cause or the type of duodenal atresia, because there are different types. And of course, once we identify them, then we fix the problem based on what we find. But generally, we do the procedure called duodenostomy, in which case we take one part of the duodenum and we connect it to the other part of the duodenum. So the child that is bulbous as it's extended in the pouch, we connect it, anastomose it to the lower part that is atretic. So there's a way we manipulate that to be able to achieve that anastomosis. And once the anastomosis takes, of course, you would know that your anastomosis is doing well once the NG tube effluents begin to reduce, over time until when, in fact, you are not getting anything anymore and everything is going caudal. So at that point, the child is due to be introduced to his or her feeding. Now, these surgeries, like every other surgery, they are fraught with a lot of challenges. Okay, a lot of challenges. It can be surgical site infection, which can be surgical site infection at the organ space or at the soft tissue that is on the skin and the muscles. It can actually affect the repair, in which case the repair can break down, be an anastomotic leak. And of course, if that happens, you may have to go back and redo the procedure. Okay. Now, one thing that I need to mention here is that some of the children that have this problem may have some form of ileus, that is a prolonged return to function of the GI. Okay, because most of the time the distal part of that bowel has not actually started working, so it has not really, peristalsis has not really been established before, because duodenal atresias, they develop much earlier compared to intestinal atresias. Okay, so that is the problem. So they may have some form of prolonged ileus, which means that we need to be patient with these children, and where there is parenteral nutrition, it should be part of the care of these children until they are able to establish normal GI function. Where outcomes are good, you can, when you intervene, you can get between 90 to 95% success rate when we do that. But of course, the premorbid conditions, rather associated conditions, can limit the outcome. For instance, patients that have severe prematurity, patients that have severe congenital anomalies, okay, patients that have associated lung challenges can have some form of increased morbidity and mortality. But by and large, if you intervene and everything goes well, outcome usually is good. Even in those that have Down syndrome, outcome is good.
Okay.
I don't know if you had any questions.
Any questions? I saw Dr. Bibama raising hands. Okay. I don't know whether you drop any question. Okay.
Ready, question.
No. So these are just comments.
What is the comment?
Your volume is too low, please.
Okay. Sorry about that. Okay. All right. So, like we said, we talk about intestinal malrotation and volvulus. This is a very dangerous, one of the most dangerous conditions in the newborn, I must say, because it is common. I have about 1 in 500, live births, and commoner in male than female, in the ratio about 2 to 1. About 80% of them will present within the first year of life. But we're talking about the newborn. Okay, for children that have this, within the first month, about 50% of them would present. So within the first 28 days of life, children that have intestinal malrotations are likely to present. And again, like we said at the beginning, there are several people that have intestinal malrotation that are enjoying their life, they have no issues at all. So we are concerned about those who have issues and are presenting to us. How do they present? Next slide.
So I also remember the 5-year-old girl that we managed last year. The one that with malrotation, that eventually they traveled out of the country, but the child was still fine. So 75 by 1 year, that means more after that. You can find more. So we've experienced cases here.
Yes. What is the cause of intestinal malrotation? It has to do with what we talked about the other time, that within the first 4 to 6 weeks of life, there's a rapid growth in the size of the intestine. And this growth is so rapid that the primitive abdominal cavity becomes too small to accommodate it. And so part of it now herniates into the extracoelomic cavity. Now, as this is going out, there is a counterclockwise rotation of the bowel, and it achieves about 270 degrees of this rotation. Actually about 180, and about the time that the bowel is returning back into the peritoneal cavity, another 90-degree twist. Now, this leads to the adjustment or the alignment of the bowel within the abdominal cavity the way we see it. For instance, the intestine is survived, that is the midgut. What we call the midgut is survived on the superior mesenteric artery. Okay, so of course, when we talk about the midgut, we're talking about the second half of the duodenum up to the proximal third of the transverse colon. That's what constitutes the midgut. So all this survives on the superior mesenteric artery. The remaining part is supplied by the inferior mesenteric artery. Now, so this twist, eventually in the counterclockwise, is what defines, for instance, where you now see that the duodenum lies inferior to superior mesenteric artery in the real, if you look at in the real life. Okay, so it lies, and then that's what explains why at the end of the day, when you see that the transverse colon, the mesentery is below and transverse lies across, at the level of the transpyloric plane. You see the transverse colon lies in that orientation. And of course, that brings, so when the bowels are returning back into the peritoneal cavity, because they herniated with their mesentery, this mesentery gets eventually absorbed. Okay, so the malrotation is a problem of both rotation and fixation anomalies. Now, if this return of bowels occurs en masse without it following the due process, as we said, we will have a situation where the intestine will appear to be clumped together and bound together with some fibrinous, with some tissues like that. Okay, and you will not be able to differentiate the cecum in its normal position and the ligament of Treves from its normal position. You just see that the bowels will be lying in the center of the abdomen. Sometimes the return is such that only part of the colon is fixed and the cecal part is not fixed, in which case we could call a floating cecum. The cecum is just floating. So the cecum, the bowel has returned, but because of some failure of fixation, that part of the cecum of the colon is now mobile. And this creates a potential risk. Of course, sometimes this fixation and anomalies can create pouches. These pouches now provide recesses through which some part of the bowel can actually get entrapped, leading to what we call internal hernias. So that's why malrotation is a very dangerous thing. Now, when it happens and there is volvulus, remember that the whole of the midgut is sustained on superior mesenteric artery. So the volvulus is a twisting. It's a twisting. When that twisting occurs, what it does that it stands the risk of devascularizing the whole of that segment of the bowel. And if that happens, that child is going to end up with what we call a short gut syndrome. And the short gut syndrome survivor in our environment is very, very poor. Very, very poor. So whatever we can do to avoid it or to manage it, once we see one case is very, very important, and we'll do all that we can do. Next slide. So, so this child will present, because of the obstruction, proximal obstruction, present with vomiting, That vomiting, usually within the first 24 to 72 hours. Like I said about duodenal obstruction, atresia, the same thing happens here. So you need to be able to differentiate between the two, because both of them, the obstruction is below the level of the second part of the duodenum. So bile will not have to accumulate, and that's why the patient, has bilous vomiting. But if the atresia is above the level of the second part of the duodenum, of course, like you have in pyloric stenosis or pyloric atresia, the vomiting will be clear fluid. It will not be bilous, because there was no way bile can find its way into the stomach. So that is what explains it. So that's why when concerned when the child has this, how do we then diagnose intestinal malrotation? If you do your plain abdominal X-ray, you may not find anything very classical. May not. But if we do a contrast X-ray, maybe we do it an upper GI series or barium swallow with a follow-through. Now, that may give it away. And what are the pictures we're going to find? In the case of a pure intestinal malrotation, now the normal orientation of the bowel is that you have the ligament of Treves, which is at the junction of the jejunum and duodenum, in the fourth part of the duodenum, to the left upper part of the spine, just below the level of the costal region. And then, of course, that mesentery runs towards the right iliac fossa, where you have the cecum. Okay, so you have that line in that diagonal fashion. Now, in patients that have intestinal malrotation, for instance, that those that have non-rotation, you may not find the bowel aligned in that position. Okay, so the ligament of Treves that is supposed to be at that portion will now be lying abnormally low, or lies to the right of the vertebral spine, or lying on the midline. So whenever you find, for instance, that, okay, the stuff is lying on the midline, it shows that there is a malrotation. If you find the ligament of Treves lying abnormally low, rather than where it's supposed to be, there is a malrotation. And if you find it wholly on the right side of the vertebral spine, it tells us that there is also a malrotation. The other way you can diagnose this is, which of course is not very, very accurate, because it needs a lot of experience by those that have been doing it over time, is by ultrasound, where you now look at the position of the two major vessels that run in the mesentery that supply that. That is the superior mesenteric artery and the vein. The artery ordinarily should be on the left, the vein should be on the right. But in malrotation, because of the twisting, there is a change in position. The artery now comes on the right, while the vein is now on the left. And this is difficult because it's a Doppler. It is only those who know how to interpret that can actually pick it and tell you that we found this and we suspect that there's a malrotation. But even if you have done that, you still need probably a contrast to confirm it. This is one situation where we may need a contrast study in a child. But however, as pediatric surgeons, we don't have to wait for a contrast study once we diagnose the patient, a newborn patient with features of neonatal intestinal obstruction, having bilous vomiting. Exploratory laparotomy is a definitive investigation, because you open up the abdomen, you see. So exploratory laparotomy is not a procedure per se, because you're just exploring, you're just looking. But you can, with it can be diagnostic. You can use it as an access for therapeutic. So that's why I say exploratory laparotomy. When we get it, we explore. We will do what we find. So in these children, when we open up the abdomen, we will find any of these, type of malrotation, and then be addressed. Now, if we find intestinal malrotation, what do we do really? Now, remember that we said that the normally, arranged bowel is such that the mesentery runs from the ligament of Treves, the left upper part of the subcostal region, to this right iliac fossa. Now, so that is a long a well-arranged mesentery. And because of the broad base of the mesentery, it's able to stabilize the bowel from twisting. In patients that have some form of malrotation, the bowel is not that well arranged. Therefore, the mesentery is narrow, like a pedicle. So it is prone to twisting at the slightest provocation. Okay, so it's prone to twisting. So when we operate on these children, if they, for instance, at the time we see the bowel is still viable, what we do is to now release all the bands, free all the bands, and then put the bowel in a non-rotated position. In a non-rotated position is the bowel ab initio. The small bowel should be on the right, and the large bowel should be on the left. So we manipulate in such a way that we are able to achieve that. And because of the chances that, yes, this patient may develop appendicitis later on in life and wouldn't want it to confound whoever will be managing the patient at that time, appendectomy is part of what we do. So at the end of that manipulation, we do an appendicectomy so that we wouldn't have a child coming up 10 years later complaining about pain on the left, and somebody thinks that they would do a scan here and say they didn't find an appendix. And of course, not knowing that the child had appendicitis and vaginal ruptures can become a problem. So we do that. But these days, we also do a modified procedure. And what we do is that because the appendix is actually being used for a lot of things, congenital surgeries, you can use it as a part of a tube, a conduit, in doing some procedures. So we don't now discard the appendix. So sometimes we actually leave the appendix. If the appendix is not compromised, we leave it. And we instruct the parents that where the appendix is not removed, the appendix is on the left, just in case the child develops problem later in life, so that whoever surgeon or doctor that sees the patient can be well informed that, yeah, this child had this operation here. The reason is because most of the time we're going to operate on these babies, the incision that we're going to use is usually right supra-umbilical incision. Now, people will think that, oh, it's an appendicectomy that was done. So when they see that incision, they may want to think that they have done appendicectomy for the child. So we give that instruction so that they are aware, and that child is also informed in his adult life that he has his appendix on the right, just in case there are issues, so that he can be addressed. So once this is done, then of course the child is reversed, and of course it's taken back to the neonatal intensive care unit where post-operative care is instituted and the child recovers, and of course, like we said at the beginning, the complications are the same like we have mentioned earlier on for duodenal atresia. Outcome usually is good once intervention is done. But like I said, for patients that are unfortunate to have extensive gangrene from volvulus of the midgut, most of them would have very high mortality rate, because either from the mortality as a result of the sepsis following the surgery, or mortality from short gut syndrome, which is a problem because once the duodenum is not there, you're taking out most all the part where the child will use to absorb, because the cecum is not there, colon, part of the colon is not there. So you may end up having maybe a part of the duodenum being connected to another part of the colon. And see, it's a big problem. There's nowhere this child is going to be able to absorb fluids. So that is the whole essence of being very, very apt and watching out for cystic, because if you see it and you intervene on time, you can save that child. Recently, I think we had a child that for delay from HMO approvals, we suffered, that child suffered some form of extensive gangrene, and we have to recess so much of the bowel. And unfortunately, that child died after. So these are things that we can avoid if interventions are done early enough. All right.
Okay. So the warning is everybody watch out. Villous vomiting is a serious symptom that we need to raise alarm. Okay, it's better to raise a false alarm than not to raise an alarm at all. Sleep. Okay, if we look at just one case of the lower GI, then we gradually slow down to run up. Hirschsprung disease.
Yeah, well, Hirschsprung disease, what I will say about Hirschsprung disease, because this discussion is just highlighting some of the conditions, because response disease alone is something we can talk about in the next 3-4 hours. We'll not have finished discussing it. But we need to know that it's a disease that affects both male and female. And of course, somehow, diseases are commoner in males than females. And so in this case, it's about 4 in 1. What is the main problem in response disease? The main problem is that there's absence of ganglion cells in the mesenteric plexus, in the rectosigmoid area. Now, response disease is classified into ultra short, short, long, and total colony. That is, it could affect a small segment of the lower part of the rectum. It could affect the rectosigmoid area, so we call the rectosigmoid disease, which accounts for about 80% or more of the cases. But the long segment can extend from the lower part of the rectum up to the left colon, okay? And the total colonic can actually extend, involving the whole of the colon. There is also total intestinal agagnosis has been reported. That is, the whole of the intestine has also been affected. Okay, so that has been reported. But the common one is the rectosigmoid disease. Now, the absence of ganglion cells at that level accounts for some form of functional obstruction. It's not anatomic, it's functional. So these children, usually when they are born, they present with features of delayed passage of meconium. We say a child has had delayed passage of meconium if by 48 hours or 2 days of life, that child has not passed through. We recognize that as having had delayed passage of meconium. So if this happens, we will suspect the response disease, okay? And of course, some of them may eventually pass, some of them may actually pass, may not have delayed passage of meconium. But as time goes on, they may come down with some form of constipation. They may come down some form of constipation, which may be recurrent. Typically, the child may not pass meconium and may have to be assisted to pass meconium after like about 3 or 4 days of abdominal distension. And that distension will not probably lead to some vomiting, all right? And if there is no intervention in time, that child may start having sepsis. So they may have fever and all those issues that normally will follow the child. All right. Now, next slide. So when the child presents to us, of course, we will take normal history and then we'll examine. And of course, in the examination, you will find that the child is maybe pink in room air, maybe being respiratory distress, depending on the extent of the distension of the abdomen at the time. And of course, if there's already sepsis, there will be fever. Now, if you listen to the bowel sounds will be hyperactive. And if you did a rectal exam, in this case, you may not be able to insinuate your finger into the rectum, but we advise that we use the bulb of a thermometer, a rectal thermometer. If you put that in and you bring it out, sometimes you see that the child may pass meconium after that exercise. And so like I said earlier, after assisting that child to pass the first 2, they may pass 1 or 2 stools and eventually go back into that situation. Now, for some that are quite that are late presenting, you may have to do the process of digital rectal manipulation in order to decompress the abdomen, control sepsis. However, where it's difficult to achieve this, and there is the manpower. Once we've gotten this history, we've got to do a barium enema. Now, the barium enema preferably should actually be done about the second week of life. The reason being that in the early phase, what we are looking at, what we are looking for, we may not quite get it because we are trying to get the picture, what we call the classical funnel shape appearance. That period of time is not actually long enough. Actually, it takes about 6 weeks for you to be able to achieve that. So if you have done the digital rectal examination, what has happened is that there's a pressure buildup that sustains that picture. So that rectal exam or manipulation disrupts that. So that is why we advise parents that once you have done that procedure, you need to wait for a few more days to allow the pressure to build up before we go do the barium enema. So when you do the barium enema, it gives a classical appearance, what we call the funnel shape appearance. And the appearance is that you have a segment lower down that is contracted, and you have a place that is, widening up, dilating up, as so that area where it begins to tapers, when it begins to broaden out, is a transition zone. And the area that is widening out is a normal part of the gut that actually should have normal ganglion cells. But because of this, the difficulty in passing through the area that is contracted because of the absent ganglion cells, it now dilates to accommodate the intestinal content at that point. So that's why it's that. But if we've done a digital rectal, we break that. And once we break that, the pressure that is built up forces out everything that is accumulated there. That's what gives the classical sign they call a fountain sign, where, for instance, as soon as you put your finger there and you remove it, the child passes very loud, stool with gas and splashes. Okay. And for children that have already started having some form of enterocolitis, the kind of a water, the loose watery stool, will come. That's what we call the fountain sign. But for those that have not had that, you may not have that kind of classical manifestation. So once we are able to do the barium for these children, then the next thing that we do is a rectal biopsy. Okay, a rectal biopsy would confirm the absence of the ganglion cells, and we can further send those biopsies for immunohistochemistry to also tell us that there's absence of acetylcholinesterase. Okay, so these are things that will further confirm the diagnosis. These are important because the surgery we're going to do for the child may involve removing segment of the body, and it is unethical for you to remove any part of the human body without a justification for that. Now, while the child is having had this diagnosis and we are doing all this, we can do one of two things to keep the child abdomen flat and the intestines undilated, or if they were already dilated, to try to help them to return to normal by doing what we call rectal washout. We can do rectal washout once a day or twice a day, depending on what the doctor feels. But where that will not be possible, the mother can be taught to do simple digital rectal excitation, teaching the mother to insinuate her little finger into the rectum. Where she cannot do that, can get a thermometer, and they can use the bubble thermometer, well lubricated, and be doing that preferably in the morning and in the evening when the baby is being bathed. And that will help the child to pass through. Because once you do that, you break the resistance that is created by that contracted segment. Because the normal bowel is that once your rectum is full, your sphincters relaxes once the environment is conducive and everybody goes and defecates. But in these children, irrespective of how conducive the environment is, there is a failure of relaxation of the sphincters. So that's what traps whatever is in there. So these processes are done. Now, where this is not possible, the other way that we can keep these children alive, pending when they can have surgery, is to do a colostomy. Colostomy is bringing out part of that colon and attaching it to the skin so that the child can pass through. Now, the simplest procedure that people do is the transverse colostomy. Okay, you bring out part of the transverse colon, make an incision, they bring it out. I just open it down, attach it with a few stitches. The child will decompress. Where there is no access to a pediatric surgeon or somebody that has the expertise. Once this is done, the child can now be sent to a place where it can be properly managed. And of course, once the child has a colostomy, then we work up that child to have a pull-through. A pull-through is a procedure where we would, having done our barium enema, which gives us an idea of where the problem is, and having confirmed with the barium, with the rectal biopsy, then we take out the segment of that bowel, and then we anastomose the normal part of the colon to about the dentate line. Okay, once we do that, then of course the child is now able to pass through like every other normal human being. And of course, there are different ways that we do this. We can do it through the abdomen, we can do it through the rectum, we can do it laparoscopically. We can do it a laparoscopy assisted, I mean, we're doing through an abdominal or an open approach, also being assisted with the laparoscope. So once we do this, then those children were able to overcome the challenges of defecation, and that their problem would have been solved. However, the surgery can be complicated. For instance, there's an entity called Hirschsprung's disease-associated enterocolitis. Irrespective of what you do, some of these children may develop enterocolitis, not because there's an obstruction, but it's an entity, okay? And of course, when it happens, it can be deadly, but it needs concerted effort by the pediatricians who are co-managing with the patient to ensure that the child is adequately hydrated, antibiotics, adequate antibiotic cover, and other support care. Most of them will survive. Now, some of them may heal with some residual stenosis, okay, particularly for those who have suffered some form of anastomotic breakdown or following surgical site infection. But of course, by and large, some of them may require 1 or 2 rectal dilatations to address that. Okay, some may eventually have incontinence for some reasons, because during the procedure, the stretching of the anal sphincters to be able to do the anastomosis, some of them may really come with some delay in recovery from that. So they may have anal incontinence. So you can imagine a child, what we tell parents that your child has not been passing stool, but now be ready to pack stool, because you could be the one be asking, when will this stool stop? Because sometimes they've not passed stool for ages, and by the time of the procedure, they can pass stool up to 10 times a day. But as the child gets matured, the frequency and the nature, the texture of the stool, gets better. Some eventually return to normal pattern of stooling for the adult. Some people may end up with chronic constipation, irrespective of what has been done. And this may be as a result of either residual agagnosis, or some people may have what we call skip lesions. Skip lesions in the sense that there are the area that is operated upon has actually been addressed that primary problem, but they may have some areas that still have agagnosis, but are not significant. So they are able to allow the child to pass through, but it takes quite some time before they eventually pass through. Okay. Next slide.
Thank you very much, sir. We just quickly brush through some slides with some few other problems. We look at like omphalocele, gastroschisis, meconium ileus, imperforate anus, necrotizing enterocolitis. Actually, we have a case report that we're going to do at the end, a case of necrotizing enterocolitis that we are managed in our intensive care unit here. Then obstructive hernia and some other conditions. Some other urgent issues may happen. Maybe after circumcision, child will start bleeding seriously. We need the surgeons to come in. If no surgeon didn't come in, you may not be able to solve the problem. So you can classify that. Then we mentioned earlier on the respiratory, like the corner atresia and laryngeal cleft. Genesis, congenital lobar emphysema, cystic hygroma. We'll see some pictures later. And intracranial hemorrhages, fractures from either birth trauma or maybe some traditional ways, or some children can just fall accident in the house. Hydrocephalus, we need surgical intervention, posterior urethral valve, and some other critical heart disease, congenital heart disease, we need the intervention. So as we're rounding off, maybe some of these few pictures, we just mentioned some of the few differences like omphalocele,
Well, Untitled and cases, we call them anterior abdominal wall defects. That means there's a defect in the anterior abdomen resulting in protrusion of the intestine. But in Untitled, usually it comes out through the umbilical ring, whereas in gastroschisis, it comes beside the right side of the umbilicus. So you look at in Untitled, you may not find the umbilical. You may find the umbilicus either at the summit of the sac or at the inferior part of the sac. But the intestine will be intact, except when that membrane is ruptured. But in gastroschisis, there is no membrane, but you see the umbilicus, but the rent is to the right and the bowel protrudes out. These are very, particularly the gastroschisis, a very dangerous condition in the sense that this actually happens in about the 4th week of life. And so this bowel remains inside the amniotic cavity and is exposed to a lot of irritations and they usually clump together in dermatose. And if we succeed in returning the bowel back to the amniotic cavity, usually the problem that confront us is ileus. Usually about 3 weeks, these children with ileus will not be able to feed, so we need to feed them through the parenteral route, unlike the Untitled. Now, this is one condition called imperforate anus, what we call aneurethral malformation. Is a very common condition in our environment. The child is not able to pass through. So if you find a child like this, please send the child to a pediatric surgeon, to a center where the child can be managed. Because for this child to be able to stay alive, you need to have a colostomy, or depending on the type that he has, have a primary repair. Next slide. Well, next slide. This lobar, congenital lobar ependyma, some of them may end up having some form of chest intubation, chest tube, and underwater to drainage to be able to keep them alive. Choana atresia, definitely we need an ENT surgeon to address the problem of the blockage of the choana so that this child can breathe normally. Well, meconium ileus simply is as a result of thickened, insipated meconium that gets attached to the wall of the bowel, therefore making craniocaudal proposis of the meconium very difficult and therefore resulting in intestinal obstruction. So when it is found, if it is in lower down the rectum, sometimes you do a rectal washout, some of them you succeed in getting them out. If not, the child will have surgery and do a enterostomy to do a washout. Some meconium ileus, particularly among the Caucasians, are associated with cystic fibrosis in more than 20% of the cases. And if that is the case, then of course, their outcome is not as good as the ones that are not associated with cystic fibrosis in this case. This is a giant cystic hygroma of the cervical region. Problem here will be problem of respiratory distress, okay, and infection. So that means that something needs to be done to be able to address this. Sometimes we need to operate on them. Sometimes we need to do some other form of treatment to address them.
The one we managed last year, the boy is 1 year now. He clocked 1 year this week. Parents, they're doing very fine. The child is good. So this is our case report. 69-hour-old female preterm neonate that were referred to this facility. She was actually 32-week plus, birth weight of 1.4, first of a set of triplets delivered elsewhere, so as an IVF conception. The babies were fed with BMS, that's breast milk substitute from the referring center. There was a complaint of abdominal distension, vomiting, respiratory distress, child was jaundice. Among other salient findings at presentation, the child was ill-looking at presentation, dyspneic, jaundice, febrile, with a respiratory rate of 84 and had a 180, respiratory of 90 on oxygen. The baby was distended with prominent atrioabdominal veins. The child was, the abdomen was tympanitic, the organs were not palpable, bowel sound were reduced because there was erythema, and other systems were remarkable. The X-ray, the significant finding was there was massive pneumoperitoneum that was noticed. The electrolyte, there was the range. Okay, hyponatremia, hypokalemia, hypocalcemia, PCB34, the child hyperbilirubinemia, because GIT, the child has jaundice too. So the child had the fluid resuscitation, electrolyte correction, blood transfusion, with adequate respiratory support, antibiotics, and adequate thermoregulatory support. The child, of course, milk per oral parenteral nutrition was commenced. NG2 was given and also phototherapy. So the child had a respiratory laparotomy in our hospital here. And the internal findings were classical. There was feculent peritoneal effluents, okay, with copious free offensive peritoneal gas, as well as multiple ileal perforation involving about 15 centimeter segment of the ileum, which is about 30 cm away from the ileocecal junction. Section anosmosis was done, and also peritoneal toileting and abdominal wall were closed. Baby did well post-operatively after some days. Of course, remember we said baby was premature, 1.4, 32 weeks. So baby was discharged at 6 weeks of life. She's about 6 months old now, and the child is doing well on follow-up, mainly for the prematurity, but the child is doing well. So I don't know, this is one of the x-rays that shows pneumoperitoneum in that kind of case. Okay.
Now, just to say that you look at this X-ray, see the way the whole abdomen, from the diaphragm down to the pelvis. This is what we call football sign. When you do this, that's round nature you see, it's called the football sign. So if you see this, it tells you there's gas. You see that the whole bowels, the intestines were all compressed together because of the tension. So the tension.
So I just few slides about that. Risk factors are for necrotizing enterocolitis. Okay, the signs you find out above. Surgery is indicated when there's pneumoperitoneum. Other things that can be done could be peritoneal drain. And other therapies are the conservative management that can be done, like we need per oral, antibiotics, airway and respiratory support, fluid and electrolyte corrections, nutritional support, blood and blood product therapy and thermoregulation and others. So all those need to be done to make the child pass through. But it's one of the diagnoses that also the neonatologists fear. When you hear NEC, enterocolitis, is something to dread. And the advanced cases in which you need to go to theater, sometimes the prognosis can be bad, but thank God we have successfully managed this child. The child is doing well. So I don't know if anything you need to say before we do the conclusion. Okay. So neonatal surgical problems are common, and as we said earlier, high index of suspicion is highly recommended. So you ensure complete examination of newborn in the labor room immediately after birth. It's a story that you feel embarrassed after delivering a baby, and the child has unperforated and the child is taken back, even outside the hospital, has gone back home within the 48 hours when they now return that the child doesn't have anus. How would you feel as a doctor, as a nurse that took care of the child? So proper examination of the children at birth is very important, including at least confirming that the anus is there and its pattern. Some of them you can see dimple. So you should not be carried away. If you see dimple, confirm that it's actually its patterns. I don't know, sir, you have any experience about that?
Well, anal dimple does not mean that the anus is patent.
Yeah.
Okay, because there are different types of aneurysmal malformation. That's why we don't use the word imperforate anus, aneurysmal malformation, because there are different varieties. There are those that connect with the vagina, connect with the urethra, connect with and those that form membrane, and those even open into the perineum with a fistulous tract. So it's important that you confirm that there is an opening.
Thank you, sir. So early and clear communication backed up by rapid and appropriate action to reduce morbidity and mortality. So managing parental anxiety too is key, because after delivery of baby, let's say baby cry, the whole world will start knowing, my wife has given birth or my sister has given birth. What next? If there's now a problem, you know, their anxiety, their euphoria will now drop and will now start facing some other different reality. So it can be very traumatizing. So managing the parental anxiety and clear communication with them is very, very important, especially coupling with some of these procedures. It can take you to different levels, financially, time, and different other things. And eventually, some have, we talk about mortality, morbidity, some long-term sequelae. So they are all things that need to be handled with care, with empathy and clear communication. And also, we need to try to get the facts so that we give them the facts, so that I don't give them false hope or you don't give them, you don't demoralize them. So just to get the facts, and also we do what Uni Hospital is known doing. Okay, so it's better to raise false alarm, as I mentioned earlier on, than to keep quiet on a dangerous clinical sign like the bilirubin vomiting in a newborn, which is something that we need to be very careful. One of the messages we should carry: bilirubin vomiting in a newborn. Okay, so more information about our services as Lume Hospital Group. Okay, about even the previous webinar recordings and information and algorithms, inquiries and referrals. You can visit our website, www.livingchildrenhospital.com. You can visit that. We appreciate your participation. And thank you very much, sir, for coming. And for the CMEs, okay, of the webinar, of course, we said it's 1.5. Okay, so it's going to be sent to you. So make sure you send us your email. Since during the registration, I'm sure it's clear. So we'll try to communicate. Okay. I don't know whether the remaining questions are here. Always interesting. What's the place of in vitro diagnosis in developing countries where medical facilities are minimal? That's a question from from Chidera Stanley, Anthony.
In utero diagnosis is evolving in our environment, and I think gynecologists are rising up to the occasion in several places, and I think it's something that should be encouraged. It's as when you do your anomaly scans and then you pick up something, then you report, you let the parents know that you found something, and where you are not so certain what you are seeing, send the person to somebody else you think is better than you, and a specialist in that area, to look at that woman again. And it will be better, in fact, they will thank you for it, because we've had several cases referred. As a few days ago, somebody called me and said, this one of my professor colleagues, this patient of mine, we did a scan and it's like there is an abdominal wall defect with the intact membrane, and we have had a discussion, and furthering on how that woman should be delivered. So it's important that we begin to explore the frontiers of knowledge in this area that's evolving. I think it's an area to get into. Thank you.
Okay, one question here. How often do we see neck in our establishment and also maybe in the country?
Very common.
Yes.
Neck is a very common medical condition that can also present with a surgical complication. So it is in everywhere you have neonatal intensive care units, they will have a lot of neck cases managed.
Thank you.
Is that all?
Yes.
So another question for now.
Thank you for the presentation. Okay, but in case if there's any question that we've missed, you can see send our emails, send it to the question and answer, and also to the coordinators. They can always get back to the presenters and then get back to you. I appreciate everybody for full participation, and we believe that what we've learned to help care for our newborn in different centers, be it primary, secondary, or tertiary center, we come across newborns. So everybody need to have hands on deck, including the obstetricians, which we know that they are the doctors do. Thank you very much.
You can
Meet.